Next, we have Dr. Soumya Nambiar. She is the consultant pediatric ophthalmologist from POM Trust. Ma'am will be talking to us about evaluation and decision making in the management of congenital cataract. Over to you, ma'am.
So first of all, thanks to KSOS and thanks to Dr. Naveen for having given me this opportunity. And good morning, everybody. So this is one of the most controversial topics in pediatric ophthalmology, how to manage a pediatric cataract. And as Naveen has already told, pediatric cataracts are not the same as adult cataracts. So let's see what are the things that we have to think about. So we know that the global prevalence of congenital cataract, as Dr. Lucy and Naveen has already told, that it's around 2.2 per 10,000 and 13.6 per 10,000. Now, why do we need to identify these cataracts? So we need to identify pediatric cataracts at the earliest. First of all, it is to reduce the visual disability. We need to identify the child at the critical period, because you missed that critical period, you're making the child blind for life. And detection of the cataract at the earliest not only helps in giving that good vision to the child, but also helps in a gross motor and fine motor development in the child. And definitely it is an indicator for an underlying systemic conditions which can be identified earlier on and treated at the earliest for the child. So as Naveen has told, the most common cause is idiopathic, 62% literally. And inherited causes are around 22.3%. And non-hereditary causes, as you can see, involves the metabolic, traumatic, infectious causes, and cataracts which are associated with syndromes, which accounts for around 11.5%. So as he has already told, what is the importance? So first of all, in children, you're not going to get any kind of details from the child as such. So you need to have a elaborative history from the parents. So you have to ask them what is the age of the onset, whether there has been an antenatal, natal, or postnatal history, like there is a hypoxia or a hypocalcemia at the time of birth, there is any injury at the time of birth. All this has to be asked in detail. A family history of consanguinity is very important. As he has already told, autosomal dominant ones are more common. So you have to check the parents also when you are evaluating a child. And what is the vision of the child, whether there has been a history of frequent falls, because sometimes you may not get the history, so you can always ask whether the child is falling in a condition where there's a lit conditions and the child is going on falling. So that could be one of the history that you're getting. And any developmental history, any history of drug intake, like in case of nephrotic syndrome, the child is on steroids for a long time, and that could induce a cataract. And systemic symptoms that is there. So always examine the child in whole general physical examination is mandatory. And in all of the bilateral cases where you have systemic associations, always send for a pediatric consultation. You may detect some cases, like in case of a rubella cataract, you may have a heart anomaly that is associated. So that can be detected by the pediatrician better. Look at the head circumference. Sometimes you may have a microcephaly along with that. And examine, as I told, examine the family members. This should not be missed. You may have a subtle cataract even in the parents. Ocular examination is very important. Visual acuity has to be checked. A simple fixing and following light will help in knowing what it is. And resistant to occlusion. You can see that in case of unilateral cataract, the child is preventing occlusion of the normal eye. And Bruckner's test is a very, very important and a very simple test. Just look at the red reflex. See if that opacity, that red glow is not there. You know that there is some problem happening in that part. It could be a lenticular problem. It could be something which is behind also. But definitely it will give some red flag signs that you have to look carefully. And preferential looking, as you know what you do in the infants. Now, some cataracts can wait. So you can, usually you see that the cataracts which is less than 3 mm in size, we tend to wait. But more than the size, I feel the more denser the cataract, the more amblyogenic or more problem it is causing. The more posterior the cataract, it's more problematic. That is more involving the nodal point. It's going to cause more problem. So certain cataracts, like as he has told, the Mittendorf's dot, like this, you can wait and watch. Anterior dot polar cataract. But remember, in an anterior dot polar cataract, you have to look for anisometropia. It may not be amblyogenic, but anisometropia could be associated in these conditions. So these are the conditions when wherein you can, maybe in the central point, you think that the child is very small, there's a small amount of cataract, you can just manage with a plain dilating drops like a tropicamide for the time being, till the child is ready for an anesthesia, till the child you can take up for cataract. But again, you have to remember that follow up these childs very closely. They may progressively increase. So that is very important. Don't let them off that, okay, it is a small cataract, nothing is going to happen. They may progress. So you have to be very careful. Even the blue dot cataract, which is seen in Down syndrome, they may be amblyogenic. You have to follow them up. They may progress to a total cataract also. Then needs intervention, as I have told, more than 3 mm in cases of these lamellar cataracts and embryonal cataract, you may need to interfere at the earliest. Persistent fetal vasculature is one of the most complicated type of cataracts. Ma'am will be talking about it, I suppose. And it can present in varied ways, like these retrolental membranes. Whenever you see the ciliary process, the vascularity developing, you have to be very careful. Look at the eye carefully. There may be a microcornea associated. Usually these are unilateral kind of cataracts. And you have to be very careful because they are commonly associated with glaucoma as well. So, always see if the child is having strabismus, nystagmus with cataract, the cataract is visually significant and you have to intervene at the earliest. Always check the intraocular pressure. You have to rule out glaucoma, like how I told in congenital rubella, it may be associated. Don't ever hesitate to take the child under anesthesia to evaluate it. Okay, sometimes the evaluation may be done just before you're planning a cataract surgery. Remember to look at the pupillary response. It's very difficult to get in a child, but it definitely helps in ruling out any retinal or posterior segment causes. And a direct and indirect ophthalmoscopy examination is important to rule out the posterior segment abnormality. Whenever you see a cataract, if you're able to see the fundus, so if the cataract is not very dense, most of the time you'll be able to see the fundus. Then you can tell whether there is any pathology or not. But in other cases, you may have to go on to do other investigations like B-scan and all. Then lab investigations, the routine blood and routine investigation, complete hemogram, the blood sugar and urine microscopy has to be done. And other tests based upon the type of cataract you can order. Okay, and that already Naveen has already told about it. So as I told, a B-scan is mandatory. 2 things that it helps. One, in dense cataract, it will help in knowing if there is any retinal pathology. Other thing is it also gives you an axial length. So if you're not able to get an axial length in a child, it will help you to know the axial length as well. And ultrasound biometry and handheld keratometry usually is done at the time of the eval. Then the recent advances, that is genetic research, is the recent thing that has come forward. So basically, it's been found that more than 100 genes have been identified in congenital cataract. And as he has told, most of the cases are idiopathic, but we do not know. We have not done a genetic analysis for most of it. A non-syndromic cataracts could have a mutation of crystalline proteins, like what he told about connexins and all. So just remember that 100 genes have been identified. So there may be some association like that. So these are the various genetic tests that have been are being done nowadays. And the cost factor is also reducing in this time period, the NGS and the whole exome sequencing. And this CAT map, which I have written in the end, it's a database which tells each loci of the cataract, where it is and what type and syndromes that is associated. So this could give an idea of the gene that is involved. So this is a database that is freely available. So a prenatal diagnosis. So if you have this diagnosis, you can always use these non-invasive methods and prenatal 3-dimensional ultrasound to detect if the child in utero itself is having a cataract. So now, when to operate a congenital cataract, whether to do early or whether to do late. And early surgery is always associated with some anesthesia complications and the problem with glaucoma. While in a late surgery, it will cause more of stimulus deprivation, amblyopia. So what is said is that every additional week of age will reduce glaucoma risk, but will increase the risk of stimulus deprivation, amblyopia. So we all know that there is a lot of controversy in pediatric cataract. Okay, so what has happened is there are not much of clinical trials that has been done in a congenital cataract. So a modified Delphi approach was adopted. Now, what is this modified Delphi approach? So basically, what they have done is they have got all experts who are good at pediatric cataract. These experts, they have given some set of questions to these experts, asking what they do in certain situations of cataract. And they have got an opinion from these experts, and based on that, they have brought a consensus that this can be done and this cannot be done. Okay, so this is just a consensus, it's not a sure shot thing, but definitely it will give us an idea of what has to be done in early cases. So these experts have come to the consensus where all these things has to be done. That is, early screening has to be done. If it is a unilateral cataract, a surgical intervention has to be done at least by 6 weeks. A bilateral cataract by 8 weeks at least, okay? And a 1 week gap in between the cataracts. And the surgery option that is usually done is a microincision cataract surgery with a posterior capsulotomy and anterior vitrectomy with an IOL. So IOL, when is it put? Whenever the child is more than 2 years. That is the consensus that is brought forward. And you have to see if the corneal diameter is more than 10 mm and an axial length of more than 17 mm. PPC with anterior vitrectomy has to be done at least till 4 to 8 years of age. Beyond that, if the child is cooperative, you can go on for a YAG capsulotomy. But note the point that multifocal or toric lenses were not recommended. Okay. And what is the consensus of secondary IOL implantation? That is, you have done initial surgery, you have left the child aphakic, and when do you implant a IOL? By 4 to 8 years of age, in cases of children who were contact lens tolerable. In those cases, you do a secondary IOL. And it can be done even early if they are not ready to wear contact lenses, if they are coming from very far off places, or some syndromic child but has a development of the cornea and this thing has occurred. An iris claw lens with no capsular support can be used. A silicone contact lenses is usually used in a child who is aphakic but less than 3 years. No consensus was still, in spite of asking these experts, there was no consensus regarding these following things. That is, IOL implantation in children younger than 2 years. So there was a meta-analysis which showed that if you implant primary IOL in less than 2 years, they had a better visual acuity if when compared to a group which were aphakic and had contact lens wearing. But they had increased chances of posterior capsular opacity. And in that group, it was seen that the prevalence of glaucoma and strabismus were similar in both groups. But what they recommended is when you are putting an IOL, it has to be optically captured or it should be a bag in the lens type of IOL. And they also said that even in these less than 2 years, IOL implantation should be delayed if there is microphthalmia. And the consensus again was not there if what type of IOL material has to be used. So most often what we use is hydrophobic acrylic. But hydrophobic acrylic, the problem is that it has got this kind of glistening to the IOL. Okay, so there is no consensus. I'll just use 2 more minutes. There is no consensus like these glistening will cause reduced visual acuity. So the trial was not done regarding that. And the power calculation, usually we use Holiday 2 and SRKT, but which is correct has not been still got. And it's been found that less than 50% of children in 5 years of follow-up had found to have were within 1 diopter of target refraction. That is, you know that a hyperopic after doing a pediatric cataract surgery, there will be a myopic shift. So you may tend to make them more hyperopic. Okay, but at 5 years of follow-up, less than 50% were found within 1 diopter of target refraction in those cases. And there was no consensus whether intracameral antibiotics has to be used or not. So postoperatively, refractive correction has to be given. This is as such, postoperatively refractive correction has to be given and occlusion therapy has to be started at the earliest. Watch for glaucoma and strabismus. You need to have a long-term follow-up, may need membranectomy or YAG capsulotomy at a later stage. And these are the factors which will affect the visual outcome, that is the age of onset of cataract, the laterality of the cataract, whether it's associated with the ocular and systemic conditions, and the age when cataract surgery is performed. adherence with optical and patching therapy is necessary. You have to confirm that with the parents as well. And so what's the take-home message? Congenital cataract is the first step towards management. Always tell the parent this is just the first step. You need to follow up. You need to be compliant with all the things that has been done. Otherwise, a well-done cataract surgery is going to be totally waste. A clean aphakia is far better than a badly done pseudophakia. Occlusion therapy at the earliest, especially in unilateral cases. Better to avoid IOLs in the first stage if corneal diameter is less than 9 mm or associated with uveitis or any other issues is there. And a need for long-term follow-up has to be re-emphasized always. So thank you.